I want to talk about the stage 4 patients who maybe require infusion therapy. How have you managed that, and what does that look like at Memorial?
We never stop treatment for stage 4 patients that need infusions. We even when we downsized the operations, we were always available to continue therapy. I am a firm believer that the patient with the stage 4 lung cancer is going to have a chance if we fight very hard for him. So we cannot start to be nihilistic or negative to say, oh, it's a stage 4, he's not going to survive. What's the big deal to give him the chemo this month or next month? No. So we have stage 4 patients that have been cured. Now we have data with immunotherapy that 20%, at least 20% of people treated with pembrolizumab or nivolumab is alive 5 years later. You are not going to find these patients if you don't do the proper thing. In this specific case, that was the reason why we cannot stop treatment. And we explained this to our colleagues in the healthcare systems that these cancer patients, they don't have the best prognosis, but we can make a difference in the lives of most of them if we continue chemotherapy or we continue especially immunotherapy, because as you know, now pretty much we use immunotherapy for lung cancer for a couple of years. So that's why it's very important that the patient gets this maintenance immunotherapy for a long time. That is going to make a difference in his progression-free survival and later in his overall survival. That's why we never stop treatment for our patients. Of course, we have a lot of patients, and it's a risk for everybody to have a large number of people in the clinic, and it's a risk for the doctors to have a lot of doctors in the clinic. So we have to take a lot of measurements that we can discuss when you ask other questions to minimize the risks. There is a little bit of flexibility, for example, in the regimes. As most of you know, nivolumab is we start to use every 2 weeks, but the label allow us to give every 4 weeks. So I guess if you had a patient, a survivor on nivolumab for not for more than a year, you can easily switch to every 4 weeks. So the patient only has to come during this pandemic once in the month. Atezolizumab, traditionally we use every 3 weeks because that's the way that we learn since the Empower 150 and the other studies were presented. But if you check the label, the FDA label of this drug, atezolizumab, there is a 4-week dose. So maybe, you say, oh, it's not a big deal if I bring the patient once a month or every 3 weeks. Maybe after 4 months, it's a big deal because the patient comes one less than if he comes every 3 weeks. So that is why there is a little bit of flexibility. We give durvalumab every 2 weeks for people with stage 3 as maintenance. There is no approval to give the drug every 3 weeks or every 4. But in small cell lung cancer, we have approval of durvalumab to give every 3 weeks already. But in general, we have been treating everybody.
Yeah, I think that's fantastic to hear that you've been treating all of your stage 4 patients who require infusion. And I think it's important for the patients watching live tonight or those to come back and watch this post live to understand that some of these dosing regimens have changed, and it's timely in that it's been fairly recent. So it's important that you have those conversations with your physician about whether or not that might be appropriate for you based on what you're on.